Welcome, everyone. Thank you for joining us for this inaugural webinar of the CEPR's Research Policy Network on the economics of aging and longevity. I guess because you've logged on, you know something about the RPN, but the Research Policy Network has been set up to focus on the economic implications of aging and longevity. I think they're two related but distinct concepts, and we're set up to focus from a research perspective, but also to try and feed through into policy implications. Please do go to the site to find out more. You can also register for the newsletter so you can make sure you don't miss any other future wonderful events like the one that we're hosting here today. And I'm absolutely delighted to have Amy Finkelstein as our inaugural speaker for this series. Amy, I'm sure, is known to all of you, which is why we had such interest in the event. But she's the John and Jenny MacDonald Professor of Economics at MIT. There are so many things I could highlight from her CV, but she's also currently the Vice President of the American Economic Association. She's the co-director of the Economics of Health program at the NBR. And as well as her academic output, there's also a great book that I would recommend to you to look at called We've Got You Covered, which takes just the research, but also looks at practical issues about how we might reform the US health system, which I always think is one of the few countries spending the right amount of money on health, but not necessarily in the right way. Amy's going to speak for an hour, then there'll be scope for you to ask questions. Julian Ashwin, who helps run the network with me, will manage that process. Amy's going to be talking about elderly health and longevity in the United States, evidence and implications. And particularly, not just because of Amy's research, but the topic is a superb one because, in looking at aging and longevity, there's often a very negative concept around the economics of aging, and it's a problem. But understanding how we're aging, what's happening to those extra years of life is key, and that's very much going to be the focus of Amy's talk. So thank you, Amy, for joining us, and I'm going to hand over to you now.
All right. Well, thank you very much for the invitation and the opportunity. I'm delighted to be here to talk about this work. It's very much work in progress. So there are some things we feel we've really figured out and some things we are still thinking about. So very also interested in people's suggestions and questions. This is joint work with Laurent Einev, a long-term collaborator of mine who's at Stanford. And this is actually for us, fairly new relative to a lot of the work we've been doing in the past, which was, as Andrew was mentioning, about U.S. healthcare markets. This is much more focused on the demographic transition that's occurring both in the United States and in other countries. So just by way of brief background, as I suspect is familiar to many of you, one of the, I think, more startling and striking developments over the last several decades, and this is, although my talk is going to focus on the US, this is a phenomenon that is true of most high-income countries, is that there's been both an increase in elderly life expectancy, so people who make it to 65 are then living longer. And while that sometimes conjures up, images of people living longer in very frail and weakened conditions, in fact, there's also been a substantial improvement in health conditional on age. So people are living longer and they're living healthier. And this is, not surprisingly, a major source of improvement in the well-being of the elderly. But as Andrew alluded to in his introductory remarks, it's also a huge fiscal challenge for both public pension programs, which tend to pay out an annuitized benefit. So if people are living longer, they're paying out for more periods, and for public health insurance programs, since healthcare spending is rising with age, and if people are living longer, that's more years of healthcare spending. In the United States, where we're going to be focusing today, the public pension program is Social Security, and the main public health insurance program for the 65 and older is Medicare. And so these improvements, while in life expectancy and in health conditional on age, while potentially very valuable to individuals, have created huge fiscal challenges for these public pension and public health insurance programs. So just to give you a sense, in the United States, real per capita spending on these programs has doubled over the time period that we're going to be focusing on in this talk, the sort of roughly 3 decades between the early 90s and right up to the COVID pandemic. Currently, these two programs together account for over 1/3 of federal spending. And so, we're not the first to notice these challenges. There's been enormous amounts of policy discussion, which sensibly, I think, tend to consider, the joint fiscal pressure on public pensions and public health insurance, and discuss, potential solutions, of which, primarily people talk about three main buckets. One is raising taxes on working age people to finance increased expenditures on the elderly. One is reducing benefits, generosity of these programs for the elderly. And a third, which is a form of benefit reduction, would be increasing the age at which you become eligible for these programs. So there's an enormous amount of academic and policy work on these topics, and that is actually not our focus today. We're going to take a slightly different, which is to say, given whatever the public sector budget allocation is for the elderly on these two programs, how do these demographic changes affect the relative allocation of public spending across public pensions and public health insurance for the elderly? And so, why are we doing this? On the one hand, these two large social insurance entitlement programs in the US were created at different times, Social Security in 1935, Medicare in 1965. They're funded out of different revenue streams. They're administered by different public agencies, so they might seem, quite separate. On the other hand, from the perspective of an economist, they're actually sort of fundamentally trying to do the same thing, which is to provide social insurance to smooth the consumption of elderly individuals who face both stochastic mortality, that's the annuity part, and stochastic health, that's the health insurance part. And so from that perspective, it seems like we've been a little remiss in thinking, not only about the optimal level of these programs and how demographic changes might affect those, but also about the allocation across the two programs. So we're going to try and do two things in this talk related to the question of how do demographic changes of the type I've just described, and I'll show you more detail on those, differentially affect these two programs. The first part is purely descriptive, and it just says, given the status quo policy, these are both entitlement programs in the United States, so they have no fixed budget. If you meet the eligibility requirements, they're statutory benefits. So given that policy, how have demographic changes affected Medicare and Social Security spending? Qualitatively, it's obvious that Social Security spending will increase because, as I said, Social Security is paying out an annuity per year that you're alive. And if people are living longer, that's going to be larger, and it's relatively easy to calculate how much larger. The more subtle and interesting question, which is going to be the focus of most of our work, is how these demographic changes affect public health insurance spending for the elderly. That's somewhat less obvious because, on the one hand, if you're living longer, every year has non-negative spending and usually positive healthcare spending, so that's going to drive healthcare spending up. On the other hand, at each age you're healthier, that's going to drive spending down. So we're going to talk about that. And then in the second part of the talk, we're going to move from the descriptive to the normative and ask about how demographic changes should affect the optimal reallocation of public resources between Social Security and Medicare. All right, so let me just tell you briefly about the data. As I'm sure many of you are familiar with, increasingly there's a lot of very exciting and innovative work being done in economics using, massive administrative data sets that link, across, many different domains of life, income and health and labor market outcomes and benefits. And that, that work is extremely important and exciting. One thing that we were sort of a little tickled by when we started thinking about this question is that this is actually a project that you can do with off-the-shelf data, and if similar data exist in other countries, I think it would be very interesting to see similar work being done there, because as I said, the basic trends are quite similar across countries. So what we're going to use is something called the Medicare Current Beneficiary Survey. That's an annual survey of Medicare enrollees. We're going to focus on the 65 plus in the United States. It's been conducted every year since 1992. As a brief side note, there are actually two different Medicare programs in the United States, so-called traditional Medicare, which is a public benefit, publicly administered health insurance program, and Medicare Advantage, or MA, which is in which private insurers provide the benefits to individuals paid for by the government. At the start of our period, almost all of the enrollees were in traditional Medicare. By the end, it was getting closer to half and half. We're going to be able, because we have survey data, to look at both of them. The other key feature of the data, which is going to be, as you'll see in a moment, very important in what we do, is that there's a small panel element of the data. So while you should think of it as an annual repeated cross-section, each annual repeated cross-section then follows the participants for 3 to 4 years, which is going to be very important in allowing us to construct transition matrices and see how people are moving across different health states. We're going to look at individuals 66 and over, just so make sure we have a full year for all Medicare enrollees. And just to give you a rough sense, this is going to be about 10,000 people per year that we have in the data. And so as a result, simply to make sure we have reasonable sample sizes, most of our analyses are going to consider two time periods, the beginning of our data and the end of our data. I'll refer to them as 1993 and 2017 and everything that follows, but you should know that when I say 1993, we're actually pooling 3 years of data, 92 to 94, just for sample size reasons. And likewise at the end, when I say 2017, we're pooling 2016 to 2018. All right, so the key variables, they ask very detailed information about your health, some of which, like, what chronic diseases you've been diagnosed with, hypertension, diabetes, etc., one could get in administrative data. But the other measures, which I think you really need a survey for, are what are called ADLs, or activities of daily living. So they look at limitations. They ask you about your limitations to activities of daily living. Those are things like your ability to bathe or dress or feed yourself without assistance. There's also limitations to IADLs, or instrumental activities of daily living, which are slightly more cognitive tasks, such as, being able to make a phone call or pay your bills. And then they ask about 5 functional limitations, which are, your ability to walk a block, your ability to lift 5 pounds, etc. So all in all, we have 31 different measures covering activities of daily living, instrumental activities of daily living, functional limitations, and what diseases you have. And that's going to be very important for our work. We also have quite detailed data on healthcare spending. We have total expenditures, regardless of the payer, by category of care. So we see inpatient care, outpatient care, prescription drug care, nursing home care, etc. This is self-reported, but the survey instrument links to and cross-checks that against administrative data where feasible. So for example, if you're in the traditional Medicare program, they link to your Medicare program and they can actually see, cross-validate it against your claims data. And then most importantly, and this is the only respect in which, the data are not completely off the shelf because you need to just apply for a special data use agreement, we've linked those data to each individual's subsequent mortality, if any, through 2019. All right, so these 31 different health measures that I mentioned are important. They're very granular, and we're going to use those to develop a mapping from health to healthcare spending so that we can think about how changes in health affect healthcare spending. But for some of what we're going to do, it's going to be useful to have a coarser measure of health. And for that, we're going to generate 5 morbidity groups we define them based on the sum of the numbers of limitations of activities of daily living and instrumental activities of daily living that you have. So each of those have 6 possibilities, and so the sum ranges from 0 to 12. We define group 1, the healthiest group, which is about half the sample, as having no ADLs or IADLs. And then groups 2 through 5 are roughly equally split between, based on the number of ADLs. So whether you have 1 ADL or IADL, 2 to 3, 4 to 7, or 8 to 12. And just to sort of a bit of a spoiler alert, and just to clue you in, we're going to find that it's this 5th group, this having 8 or more limitations to ADLs or IADLs, for which you see a really big difference in healthcare spending. So a lot of our results are going to be driven by, what share of the population is in group 5 or not, and how that's evolving over time. So the reason we do this sort of coarsification of the granular health is that's going to enable us to use that panel nature of the data that I mentioned on the last slide. The fact that an individual who's, surveyed in 1993 is then followed for several years to generate age and year specific transition matrices across these 5 morbidity groups and an absorbing mortality state. So in 1993 and again in 2017, we're going to calculate at each age and for each possible morbidity state that you could come into that age with, 1 through 5, what's the probability that next year you're in each of those 5 states or a 6th state, which is death. And we're going to create those age specific transition 5x6 transition matrices, both in the 1993 and in 2017. Why are we doing this? We're doing this because it will allow us to then calculate changes over time in health events for a hypothetical 66-year-old who lives their life within the year. So we're imagining a 66-year-old in 1993 who faces the health transition matrices of a 66-year-old in 1993, a 67-year-old in 1993, a 68-year-old, etc. For those of you familiar with this analogy, this is, the analog of a period life expectancy table in which we calculate life expectancy by saying, what's the life expectancy of someone today if they face the age-specific mortality rates that we observe today? So that's the same exercise we're going to do, except incorporating morbidity as well. All right, let me now just show you a bunch of just raw descriptive features in the data just to give you a sense of the pattern. In the background, I'm showing you the sort of sample size at different ages. And on the y-axis, I'm plotting just the sum, just a simple descriptive measure. We'll do things more complexly when we get later in the talk, but just for now, the number of limitations to ADLs and IADLs. So that can range from 0 to 12. Not surprisingly, that's increasing with age, because as we know, frailty is increasing with age. But the other thing that's really striking, and as I said, this is already well known, but I think you can see it quite clearly in these graphs, is that at any given age, the number of ADLs is, falling quite sharply between the beginning of our period and the end of our period. To put this in perspective, you often hear the expression that, 70 is the new 60. Well, in our data, to be a little more precise about that, 80 is the new 74. So an 80-year-old in 2017 on average, has the number of limitations to activities of daily living and instrumental activities of daily living that a 74-year-old had 3 decades before. So, fairly remarkable improvements in health. And you see that this is happening at essentially all ages. we want to ask the question, not just, how has health conditional on age changed when we measure age relative to when you were born, which is, of course, the standard way of measuring age, but you can also think of measuring age backwards as, the number of years you have prior to death. And here we can't do this with the 2017 data because our data only goes through 2019, and that's why we've brought in the 2012 data as well. And here the picture is remarkably very different. It looks like uh, if you measure age relative, backwards from the date of death, health conditional on time to death is remarkably unchanged. So another way of summarizing these two graphs is that, we're adding, additional years in good health, but once you start to get really sick, the process of dying hasn't changed very much. It's not that people are, very, very healthy up until the moment they die, and that process has changed. Health deteriorates as you get closer to death, and that sort of relationship has not changed at all. But what has changed is when you're far away from death at all ages, you're looking healthier. All right, so we can use these uh, uh, types of results and those transition matrices that I just described to you to calculate both period life expectancy, both in 1993, that's in the red, and in 2017, that's in the blue, and changes in life expectancy. And what we find, and as I said, this has been documented in many countries and in many data sets, including in the US with other data and some with these data, is this remarkable pattern of increased life expectancy at 65. So on average in 1993, a 65-year-old could expect to live about 17.5 years. By 2017, that had increased by 2.5 years. And what's particularly well, let me say two things. So one is you can then, as I said, quite straightforwardly calculate the implications for public pensions because we know what average annual benefits are. And if we just say, what if you add a couple years of expected life and you don't do any discounting or anything, you just say the expected lifetime Social Security payments for a 66-year-old have increased over this roughly 3 decades by about $44,000 or about 14%. But what's then particularly striking is you can also look at how the expected number of years in different morbidity groups has changed, again, just by calculating, running those transition matrices in both periods. And here, what you find, as I said, this has been found before, but I still find it really striking, is that all of the incremental years of life, all of that 2.5 years of additional life are years in healthy life. This is morbidity group 1, in which there's zero, you report zero limitations to activities of daily living or instrumental activities of daily living. And the other thing I just want to call your attention to, because it'll be important when we get to healthcare spending, is that it's not just that we're adding the years that we're adding are healthy years. There's also a movement from morbidity group 5, which has a decline of about, half a year on average is a decrease in the time you're going to expect to spend in morbidity group 5 to morbidity group 2. That's one limitation of activities of daily living or instrumental activities of daily living. And I call your attention to this because, as I already mentioned, and we'll see in a second, spending is much higher in morbidity group 5. So this is going to have potentially very important implications for lifetime healthcare spending. Let me just briefly mention some heterogeneity in these findings because we can look at this, separately, for example, for men and women. As is well known, life expectancy for women is higher than for men. So, for example, if you consider, say, the red 1993, women on average were living 18.8 years at 65 compared to only 15.9 years for men. Both groups improved their life expectancy, but the life expectancy actually improved more for men than for women. So that's kind of interesting. So it's somewhat of a narrowing of the longevity gaps between men and women, but also, and very strikingly, although again, they both see big improvements in the number of years spent in the best health, morbidity group 1, uh, women have a much bigger decline of 0.7 years on average in the number of years spent in really poor health, morbidity group 5, compared to men. And so the reason I'm emphasizing this is that when we get to healthcare spending, the increase in the number of life expectancy that's larger for men than women is going to be pushing up spending for men relative to women. But on the other hand, this much bigger decline in being in the worst morbidity group for women relative to men is going to be pushing down spending for women relative to men. So there'll be some interesting dynamics there. We can also do the same thing by socioeconomic status. This is a little trickier, sort of measuring socioeconomic status in a consistent way over time. A standard thing to do would be to look at education as a measure of permanent income. But over this 30-year period in the United States, the share of the elderly that are, getting some college or going beyond high school is really increasing. So you have big compositional changes by education. So instead, what we're simply going to do is define individuals at each age and each year by whether they're above or below the median income for all the individuals of that age and in that year. And because they're 66 and over, we can worry a little bit less about the natural endogeneity by which changes in health may directly affect your labor market performance and hence your income, since essentially all of these individuals are retired and their income is Social Security, pensions, and investment income for some, not labor market earnings. And so when we do that, these results are also striking, although again, the basic facts I want to emphasize have been documented before. The first is that higher income individuals, so this is above median income for your age and year, have higher life expectancy than lower income individuals. For example, in 1993, the above median income individuals were living on average 18.7 years compared to 16.2 for the below median income. Another fact, which has also been documented, is that the improvements in life expectancy have been much larger for higher income individuals, on average 3.2 years over this period, compared to lower income individuals 2.1 over this period. And the other thing, though, that's very striking is that the reduction in morbidity has been much larger for higher income individuals relative to lower income individuals. So, sorry, I actually think I said this wrong about men versus women. Here, the changes in mortality and morbidity are actually pushing in the same direction. Men are both living longer, which pushes up spending, and having a smaller decline in morbidity relative to women. So both of that is increasing spending for men relative to women. But here with income, actually you see sort of two countervailing effects when it comes to spending. So higher income individuals are both living longer, which is going to push up their spending relative to lower income individuals, but they're also getting much larger improvements in really bad morbidity, a 0.7 year average decline in the number of years spent in the worst morbidity state compared to only a 0.4 year decline for lower income. And so that's going to drive their spending down. So for men versus women, everything's pushing in the same direction to increase lifetime spending for men more than for women. Whereas for income, you have sort of two countervailing forces, and it's unclear exactly whose spending is going to go, healthcare spending is going to go up by more. And that actually sort of brings me to the core of, the novel part of what we're doing, which is, as I said, versions of the patterns I just shown you have already been seen in the United States and in other countries. Where our starting point is, what are the implications of these morbidity and mortality changes for healthcare spending? And here, as I mentioned, you have two countervailing forces that, as life expectancy increases, that's going to push healthcare spending up. But as health conditional and age improves, that's going to push healthcare spending down. And so in order to assess the net effects and quantify it, we're going to need to have a mapping from demographics, namely age and health, to spending. And that sort of where the meat of our paper begins. Before I tell you exactly how we did this, let me just show you some brief descriptive patterns. The first, here I'm showing spending. This is, I think, at the end of our sample in 2017. It's showing spending by age group on the x-axis for different morbidity groups. So first, overall, that's this dashed black line. We have the well-known result that spending is convex in age, that that older individuals spend a lot more than younger individuals. And then we've broken out spending by age separately by morbidity group. Now, of course, you need to bear in mind that the probability you're in morbidity group 1 is higher at 65 than at 90, while the probability that you're in morbidity group 5 is higher at 90 than at 60. But even still, I think there are two striking facts that emerge. The first, which I've sort of already previewed, is that the real separation of spending occurs from morbidity group 5 compared to all the others. Like, yes, spending is also increasing at any given age from morbidity group 1 to 2 to 3 to 4, but the real jump is at 5 and to slightly less extent at 4. And the other thing, oh, and sorry, and I should mention, and I apologize, I should have put this in the slides and I didn't, but if you do the same graph, but not just for total spending, but by, say, spending on different types of care, this pattern is particularly pronounced for nursing home care, and hospital care, inpatient care, right? Those are the things where morbidity group, the separation in spending by morbidity group makes a huge difference, as opposed to, and perhaps ex post, this is somewhat intuitive, physician spending and outpatient spending, where those are much more similar by morbidity group. The other thing I want to call your attention to that was pretty surprising to us is that there's a saying that age is just a number. Well, in our data, we can say that conditional on morbidity, age is just a small number, right? In the sense of within any given morbidity group, there's relatively little pattern in spending with respect to age. And that's going to be very important for some of our subsequent findings. Another way of saying it is that even this relatively crude, and we're going to do something much finer in a second, classification of morbidity into these just 5 bins is picking up a lot of what we think of as the spending age gradient. So a lot of this is really being driven just by which morbidity group you're in. All right, so now the key exercise we're going to do to think about spending implications is to map these granular measures of health, not just those 5 core spins, but those 31 underlying measures into spending, so that we can study the implications of the types of changes in morbidity and mortality we're seeing for healthcare spending. And so what we're going to do this is to train a random forest algorithm. You can just think of it as a glorified, prediction problem with a logent model to map, and to allow for a flexible set of interactions between all these 31 health indicators. So, up to, potentially 2 to the 31 of these into total spending, and also develop a mapping into, nursing home spending, inpatient spending, et cetera, each of which can be separate. And we're going to pick 1 year of data to do this mapping. We picked 2017. We've also done it with 1993. It's not consequential which we pick, but what is really important, and I want to be very clear on this because it's going to be extremely important for interpreting the results that I'm going to show you, is that we're training the mapping from health to spending in a given year. So we are holding fixed everything about the environment because we're gonna apply this mapping, to health in different years. And when we do that, we're gonna allow morbidity and mortality to vary, but we're going to say that the mapping from morbidity to healthcare spending is constant over time. What does that mean? That means we're holding medical technology fixed. Obviously, there's been huge improvements in medical technology from the beginning to the end of our period. We're holding healthcare policy fixed. In the United States, there have been enormous changes, not just in healthcare policy writ large, but specifically regarding, reimbursement of hospitals and nursing homes. We're holding that fixed. Likewise, healthcare prices fixed. So we're happening to fix them at 2017. As I said, we've done this with 1993. It doesn't make a difference. But the key thing is when we then say, how have these more demographic changes affected healthcare spending? That's holding constant everything else in the policy environment. And I mention that because I'm going to show you what I think are some pretty surprising results, and some of them are counterintuitive. And so it's important to understand that they're not about how healthcare spending has changed. They're about how healthcare spending would have changed in a counterfactual world in which we allow health to change, but we don't allow anything else in the world to change, including medical technology, healthcare policy, healthcare prices, etc. Okay, and the final thing I just want to mention about the mapping is because we're particularly interested in the mapping from health to spending, we're going to train the model just on these 31 health measures, and then we're going to take the residuals from that model and create, age-specific mean shifters based on the average residuals at each age. This turns out not to be important because consistent with this pattern that I just showed you, what we find is that once we've trained this whole model, age is hardly associated with any average impact on spending once you account for these detailed morbidities. So another way of saying this is that if you think about it sort of conceptually, why would age affect healthcare spending? Only via the effect of health, leaving aside the fact that, there are in some countries some policies that say, we're not going to recommend a mammogram after you're 70 or whatever. But to first order, the reason that age should affect healthcare spending is only via health. And the fact that we're getting very little residual relationship between age and spending, conditional on our rich health information, is to us a good sign that actually these health variables, although, on the one hand, I keep saying the rich, on the other hand, health is multifaceted and we only have 31 of them. They're doing a very good job of picking up the components of health that matter for spending. All right, so let me just show you some sense of what the prediction model generates. Here, I've generated predicted annual healthcare spending in hundreds of thousands of dollars, so 20 is like $20,000 by these 5 course morbidity groups. In the background, I'm showing you the share of the population in each of these groups. And what you find, not surprisingly, health is increasing with morbidity group, but there's variation within each morbidity group reflecting these other detailed health measures. Even if you break this out further, and as I said, there are 31 different health conditions you can have in the data. We're going to just sum up the number of those conditions. Even still, you see the same pattern, obviously, that health spending is rising in the number of conditions, but conditional on the number of conditions, there's still some non-trivial variation in healthcare spending, and we're going to be capturing that in our model and in our exercises. All right. So what's the conceptual exercise I'm going to do? I'm now going to show you what are the spending implications of these health changes between 1993 and 2017. And so in each period, I'm going to have separate age-specific transition matrices between the 5 morbidity groups and the 5 morbidity groups and death. And then within each of those age by morbidity groups, so you're 67 in morbidity group 1 or you're 83 in morbidity group 3, we're also going to take into account that the distribution of much more granular health, those 31 dimensions, could also have changed over time. So we're trying to account for, all the changes in health, and then we're going to use this mapping from granular health and age to predicted annual spending constant. And again, holding the medical technology, the policy environment fixed, the prices fixed at current levels, say, counterfactually, if nothing else in the world had changed, how would these demographic changes have affected lifetime medical spending? A 6-year-old. All right, let me show you those results. Lifetime spending is about $400,000 in 1993. Again, these are 2024 dollars, but we're not doing any discounting for now. And that uh, went up by about $25,000 by 2017. So, one way to think about that is that in practice, what we calculate is that Medicare, the public health insurance program for the elderly, only pays uh, about half of elderly healthcare spending. The reason for that, by the way, is that Medicare, and I think this is true of many other public health insurance programs in other countries, including the United Kingdom, really does not pay for much long-term care, nursing home and home care use. I'll discuss in a minute. There's another public program that pays for that, but you want to think about the increase in Medicare spending as being about half of the increase in total spending that I'm showing you here, which is about a 9% increase in Medicare spending. Now, something interesting we can do here is ask, what happened to different types of healthcare spending, and this to me is a very, very striking result, which is, I've written myself a number of papers and I've read many papers that begin with some, that are about nursing homes and long-term care and begin with the generic motivation that, as life expectancy increases and the elderly are living more into this oldest old category, the share, that are 85 and older, and we know that nursing home use really goes up with age. This is going to create a lot of increased demand for nursing home use and put pressure on nursing homes and public funding for nursing homes, et cetera. And therefore that motivates, whatever I'm doing at the moment, studying long-term care. It actually turns out that that's not right just from the demographic changes alone. That's not to say that nursing home utilization and spending hasn't gone up over our time period. It has, but those are due to policy and other changes. If you just look at how demographic changes themselves, this increase in life expectancy, but also improvement in morbidity, has been affecting spending by types of care. The big increases in spending are in outpatient spending and prescription drug spending, with very little or even negative effects on hospital care, on nursing home care, and home health care. And the reason for that is that and as I said, I should have put this graph up to show you, the major predictor of nursing home use is being in morbidity group 5. And even though people are living longer, as I showed you in some of the earlier pictures, and I'll just flip back to it, here's the main result. On average, the number of years spent in morbidity group 5 is going down. And that is actually saying that nursing, despite the fact that the population life expectancy has gone up, and despite the fact that, we know that the aging of the population is very important, that being older is a very big predictor of nursing home use, we're getting sufficiently healthier at these older ages that nursing home use, home health use are not going up. Inpatient care, inpatient spending is barely going up as well. So I think that's quite striking and quite interesting. So let me mention one other thing, which is you can do the sort of counterfactual exercise of, how much would medical spending have gone up if counterfactually we'd had the improvements in life expectancy without the improvements in morbidity, and then this number is much higher. So on net, the two forces are increasing medical spending, but if you'd had the reductions in mortality without any, changes in morbidity, you would have gotten more like $80,000 increase in total medical spending. So another sort of point of interest. All right, you can do the same sort of exercise by gender and by socioeconomic status, and I already, I think, previewed the results, which is men are going to have a much larger increase in lifetime medical spending than women, close to $50,000 compared to less than $10,000 for women. And that's because of these two reinforcing effects, that men had both a greater increase in life expectancy and a smaller decline in the time spent in morbidity group 5. Whereas when you look by income, there's more of this offsetting effects, because remember, higher income individuals have both a greater increase in life expectancy, which is pushing up spending, but also the greater decline in the probability of being in this worst morbidity group, which is pushing down spending. So the differences in, increased lifetime medical spending by income are much less stark than by gender. All right, so taking stock, what have we found? We've used the demographic changes to estimate that total public lifetime spending on pensions and health insurance for a 66-year-old have increased by about $56,000 from 1993 to 2017, and that about 3/4 of that increase, $44,000, are coming from Social Security, public pensions, and the other $12,000 are coming from that $24,000 increase in total spending and the fact that Medicare pays for about half of this. So in the second part of the talk, and I'll be much briefer on this because this is also sort of still under development, as I said, we want to move from the descriptive to the normative to ask, does this make sense? Or another way of saying it, is this optimal? How should programs adjust to these non-trivial demographic changes? Or put differently, suspend disbelief for a minute and imagine that in 1993, the allocation of the public budget between Social Security and Medicare was optimal. How do these demographic changes affect how you want to, on the margin, reallocate, the new budget? Again, the big question in this literature is, of course, how much should that spending increase? Should we finance that by reducing benefits, raising the age of eligibility for benefits, or by increasing taxes? We're not addressing that at all. We're just taking the spending increases given and asking the question about the reallocation between Medicare and Social Security. And so for this, we're going to need a very simple model. It's going to abstract from many things, as models do. What we're going to do is we're going to write down and calibrate a dynamic optimal consumption savings model of a risk-averse retiree who's retiring with a stock of wealth, Social Security, pension, and access to Medicare, and faces both stochastic health and mortality, which we can calibrate from our data. And then we're gonna do the we're gonna say how, under a given set, mortality and morbidity, what is the optimal allocation of the public spending between Social Security and Medicare, and how does that change given the demographic changes we've seen? Okay, so the model, as I said, is very stylized. We're going to have individuals begin their elderly life at 66 with an exogenous stock of initial wealth and their discrete health status, their health at 66, which is just which of those 5 groups they're in. We're going to assume constant relative risk aversion flow utility from consumption. We're going to assume no bequest motive. We're going to also abstract from state-dependent utility and allow and assume that the curvature of utility over consumption does not change with health. And then we're going to assume that health, including mortality, follows an exogenous Markov process. So your probability of death at a given age is simply a function of your health status, which of those 5 bins you're in at the previous age. And the probability you're in a given health status at age A, conditional on being alive, is simply again, those morbidity transition matrices. It's a function of what your health status was at the previous age. And finally, we're going to have a distribution of medical spending at a given age as a function of your health at that age. And we're going to abstract from all the things that my co-author Laurent and I have thought about in all of our other work, such as, the endogeneity of medical spending and how it's chosen in part based on your wealth and in part based on your health insurance. And instead, we're just going to think of medical spending as non-discretionary. So whatever health shock you get and the predicted medical expenditure associated with that shock has to be spent. Whatever isn't covered by Medicare has to be covered by the individual out of their own pocket. And so as traditional in these models, we're going to also assume that the government guarantees a minimum level of consumption, a consumption floor, which we're going to call CEPR, which you can loosely think of in the United States context as Medicaid Medicaid, which is the public health insurance program for low-income individuals in the United States. But for the elderly, where a lot of Medicaid spending is, even if you're fairly high income, you can become eligible for Medicaid if you have a series of sufficiently large medical expenditure shocks that you spend down your assets to the point where you're now indigent, even if you weren't before, and then you become eligible for Medicaid. So you can think of Medicaid as basically guaranteeing some minimum floor of consumption of non-medical expenses, because if you otherwise exhaust your assets, it will come in and pay those medical expenses. And then at some points that I'll talk about in a minute, we'll add moral hazard to that mix. Okay, so the objective function of the individual, they can save, but they can't borrow. This is standard in these models because there's stochastic mortality and we don't want you to be able to die in debt. So that their consumption choice has to be at least, between CEPR and the maximum of this consumption floor, and how much they could consume given the wealth they come in with, the Social Security benefit payment they get, and the medical spending they have to pay out of pocket, where social SS is the annual Social Security annuity and lambda is the share of medical spending covered by Medicare. What isn't covered by Medicare has to be paid out of pocket. So with that, they're going to choose consumption to maximize their lifetime present discounted value expected utility. According to this Bellman equation, you have utility this period, and the next period you have some discount rate. There's a probability you're still alive, in which case you have a draw of health and a draw of medical spending conditional on your health, and then you make the same decision again, with wealth evolving according to this wealth accumulation equation, where you go into the next period with your initial wealth plus your Social Security minus your consumption minus your out-of-pocket medical spending. And for simplicity, for now, we're going to assume assume no discounting and no interest rate. So the optimal consumption path, if you're fully annuitized, would be constant. Okay. And in this scenario, we're going to ask, what is the individual's value or willingness to pay for alternative budget neutral allocations of an exogenous public budget between Social Security and Medicare? So we're going to say, what is the amount the individual could pay that would leave them indifferent in a utility sense between paying that amount and remaining in the baseline policy or receiving the alternative policy? And the key comparative static we're going to be interested in is the relative willingness to pay for an additional expected dollar of Social Security benefits relative to Medicare benefits, and how that relative willingness to pay for Social Security versus Medicare changes with these demographic changes. Or in other words, on the margin, has the value of Social Security relative to Medicare gone up or down with these demographic changes? And when we do this, holding constant the public budget, that public budget is going to account for Social Security payments, for Medicare payments, and also for the endogenous public payments that come from the guaranteed minimum annual consumption level CEPR. So for example, if in response to more generous benefits, you decide to consume more, and that increases the probability that you end up, relying on Medicaid, that public expenditure to Medicaid will be factored in. Okay, before I show you the results, let me just outline the key economics, because this to us was a little surprising. It turns out that if you abstract from moral hazard for a moment, that Medicare is going to always dominate Social Security, that the willingness to pay for an extra expected dollar of health insurance benefits is always going to be higher than the willingness to pay for an extra dollar of expected Social Security benefits. And this result greatly surprised and puzzled us. So it took us a while to understand it. Now, of course, it's ex post obvious, but I wanted to explain where it's coming from. There's two reasons why Medicare is more valuable to a risk-averse individual than Social Security. The first is just the basic static risk smoothing argument, going back to Arrow 1965. One way to think about this is that Social Security, which are mortality contingent or survival contingent payments, are helping to move resources between the state of the world in which you're alive and the state of the world in which you're dead. But there are also multiple states of the world in which you're alive, in which your health varies. And Medicare, or public health insurance, of course, only pays out if you're alive. So it's also moving money from the state of the world in which you're dead to the state of the world in which you're alive. But it pays out differentially depending on your health state. So it's doing more risk smoothing within the states of the world in which you're alive. So that I think is relatively familiar intuition. The one that was new to us, or at least to us, and is the primary one that turns out to be affected by improved health, is what we call this sort of dynamic backloading. So if an individual, forget mortality risk for a second, if you just, I'm sorry, forget morbidity risk for a second, if you just have individuals who who face stochastic mortality and they're retired with a stock of wealth, if they had full access to actuarially fair annuities, their optimum, this standard result going back to Yari 1965, would be to fully annuitize and therefore have constant consumption each period because we've assumed, that the discount rate and interest rate are the same. If in fact, as is the case in most countries and certainly in the US, that they don't really have access to private annuities, the market is very small and the loads are large, so let's just assume they don't have access to it, then the individual is going to, without any access to annuities, is going to prefer to front load their consumption. They're going to have a downward sloping optimal consumption profile. Why? Because the technology by which they can move money into the future is quite costly to them, because if they die, that money gives them that they've saved for the eventuality of being alive provides no value for them. So even though if they had access to annuities, their optimal consumption stream, their first best would be constant consumption. If they don't have access to annuities, they're going to front load their consumption. And so with that in mind, if a public pension system like Social Security comes in for some, you have some private wealth, but you also have this public pension system, then the optimal Social Security payment benefit structure is actually backloaded. It actually, as we show in this companion paper that came out a few weeks ago as an NBR working paper, the optimal Social Security is a deferred annuity in which it pays nothing for several periods and then eventually goes to a constant consumption, a constant annuity payout. And the time period for that deferral, optimal deferral, is increasing in wealth. So if you have no wealth, then Social Security should start immediately paying a constant amount, and that would replicate the first best constant consumption period. The more initial wealth you have, the more backloaded it should be. Why am I telling you all this? Not just to, get free PR for a different paper, but because what turns out that's happening with Medicare is that in fact, in the United States, Social Security payments are constant with age. The benefit amount is not increasing with age, right? But health is worsening with age. And so in that world, if the optimum thing was to backload your annuity in Social Security, and we're not doing that, then Medicare is facilitating some of that backloading because the expected Medicare payments are increasing with age as health worsens. So in a sort of very second best sense or third best sense, when individuals don't have access to private annuities and the public pension system is not doing this optimal backloading, that's another reason that individuals are going to value Medicare on the margin more than Social Security, because it facilitates that backloading. And therefore, for some of our results, we're going to add some realistic reason why people might not actually like Medicare as much as Social Security, just so we can get an internal optimum, which is the classic moral hazard result, or the classic difference between cash and in-kind payments. Medicare is an in-kind payment. It lowers the price of medical care. That can increase consumption of medical care, which drives up costs, but not all of that increased consumption will be as valued as, what you would have chosen to do if you had to pay for it yourself. All right, let me just, with that in mind, show you the baseline results with no moral hazard. The same results hold with moral hazard, except A, the model gets more complicated because we have to gin up the moral hazard, and B, we do that because now you can get an internal solution in which, at baseline, it wasn't optimal to put everything into Medicare. So we're going to calibrate the model based on the health and mortality transitions I've showed you and the predicted medical spending that I've showed you. We're going to assume a constant relative risk aversion coefficient of 3. We're going to assume everyone's dead at 100. We're going to assume a baseline wealth of about $150,000. We can do it for other wealth as well. And then we're going to just basically take current policy parameters. Social Security payments on average are about $21,000 a year. Medicare coverage, I said, is about 50%. And then for C floor, we're going to choose the level of income in the supplemental security income program in the United States. That's the cash payment program for low income individuals in the United States of about $11,000 a year. So that's basically saying, you know, Medicaid will come in and cover up to the point where we're guaranteeing you at least that publicly provided minimum $11,000 of consumption a year. And then we're just going to solve the model, you know, using both the 1993 health distribution and the 2017 one. All right, let me just show you some very, you know, give you a flavor of these results, and then I'll wrap up. So what we're showing you here is the willingness to pay for a dollar of average, an expected average dollar of spending on Medicare or on Social Security, given these program parameters and given either 1993 demographics or 2017 demographics. So a couple things jump out. The first is all these numbers are above 1. That's just coming from risk aversion. Your willingness to pay for an expected dollar of insurance benefits is more than $1 because you're risk averse. The second thing that should jump out is that, as I foreshadowed, because we have no moral hazard here, we're finding that, you know, the value or willingness to pay of $1 for $1 of Medicare is always higher than $1 of Social Security, both in 1993 and in 2017, and for lots of other parameter values that I'm not showing you. And that's precisely those two features that I was mentioning: the better static risk smoothing of Medicare and the better dynamic risk smoothing properties of Medicare. But the main result that we're finding is that the relative value of willingness to pay for Medicare versus Social Security is declining over time. So in 1993, people valued $1 of Medicare for 70 cents on the dollar, 70 cents more than Social Security. That's gone down to only 40 cents in 2017. And if we gin up moral hazard, you get the same qualitative finding. We're not fully done with our probing of this result, but I think the intuition for this can basically be seen as the following, which is, remember I said we're adding healthy years of life, right? So we're basically, you know, one crude way of thinking of this is, you know, a 66-year-old today in 1993 is like a 61-year-old today, where we've just added, or actually, I'm sorry, not a 61-year-old, I guess more like a 63-year-old, because it's about 2 years, added 2 years of healthy life. And imagine in the extreme in which in that healthy life, there was no medical spending. Now, that's not quite right, where there's small amounts of medical spending, even in the healthy state. But in that situation, effectively what's happened when you've added 2 years of healthy life is you've made an individual with a given stock of wealth at retirement poorer, because it needs to be spent over more periods. And so therefore that's increased the value of a Social Security annuity, because you're you're increasing your consumption in every period, and your consumption has just gone down. So we think that's the intuition. We have a lot more to do, of course, to fully understand it ourselves, let alone explain it. So let me just sum up on where we are. The first set of findings, you know, which replicate other findings in the literature: the elderly in the last 25 years, between 1993 and 2017 in the United States, gained almost 2.5 years of life. And all those incremental years were healthy years, no limitations to activities of daily living or instrumental activities of daily living. The implications of this holding program design fixed is that this puts upward pressure on healthcare spending of about $25,000, and so on Medicare spending of about $12,000, and on public pensions of about $44,000. And as I said, the impact on Medicare or healthcare spending writ large would have been much larger, more like $80,000 rather than $24,000 if we hadn't had those improvements in morbidity. And so then in the final part of the paper, we're trying to ask, should the allocation across these two programs adjust? And our results are suggesting yes, that these demographic changes are on the margin increasing the value of public pensions relative to public health insurance. So I will stop there and try to unshare my screen so that I can see people. And I look forward to people's comments and questions.
Thank you very much, Amy, for a fascinating presentation. I think a great start to the webinar series for the CEPR. As Andrew said at the beginning, this is our first time running a webinar with this format. So please let us know as attendees how you think that's working on that front. We look forward to all the questions you have. I'll get started on those in a minute. For all of those attendees, please type your questions into the question and answer box there rather than raising your hand. That makes it easier for me to have an overview. And we'll try and stay on top of those and get as many of those covered as possible. So to get us started, we've got, I mean, it's not necessarily a question, it's more of a request, but I think it links to a broader issue, which is from Mark Venning asking if you could refrain from using the term elderly, arguing that that's an outdated term, and WHO and UN say older persons rather than elderly. And well, so I was wondering what response you have to that, but I think it links more broadly to questions about your model in that you are kind of, if I understood correctly, you're assuming the model starts at 66 and then there's no labor supply decision or anything after that point, and there's not any flexibility or shifting in that 66 age. So I guess a broader question there is that plausible empirically? I mean, anecdotally, I think there is quite a lot of labor supply happening after 66, certainly in a US concept, in a US context, and that is going to be affecting that trade-off between these different programs. But also, would shifting that eligibility age, if you made that a third kind of control variable for the policymakers there, you can decide, should we pay Social Security, should we pay Medicaid, or should we shift that age backwards? Do you think that would change your results at all?
Yeah, so those are both great comments. First, I apologize. I was not familiar with the preferred terminology, and I'm certainly always happy to, default to whatever is considered standard and best practice. So I will try to use older person for the remainder of this discussion. Second, the question you bring up is a very good one, and we've deliberately kept it out of scope here because as I tried to, not that it's not important, but as I tried to say at the beginning, it raises a whole set of other really interesting questions in which, the first thing I would like to do, one can imagine in the same way that we've developed a mapping from health to healthcare spending, one could develop a mapping from health to labor force participation and then say, how should this be, we would predict this should affect labor force participation at 60, 65, 70, et cetera. And what are the implications of that for the optimal, say, eligibility age in both these programs? And that is also one of the things that people think about in terms of how to deal with the fiscal pressures on these systems. You can raise taxes on the working age population. You can increase the age of benefit eligibility, or you can cut benefits among those who are receiving it. And I think those are incredibly important and interesting questions. We may try and get to them next. We were trying to say, holding that fixed, and we're not saying it should be held fixed, there's also a question of whatever we decide is the benefit structure and the age of eligibility, how does the optimal allocation between Social Security and Medicare change? So I guess one way to ask your question, or one way to answer your question, which I'm just thinking about, is we could redo these exercises assuming benefit eligibility didn't start till 70,
Mhm.
right? Yeah, so we could do that. And we could also redo all the predictions on spending. And I suspect you would get qualitatively similar results, but I would need to do it to be sure.
Thank you. That's a really interesting answer. And so driving a little bit towards that trade-off between Social Security and Medicare, you're talking about your consumption smoothing with respect to two different shocks. I was wondering if you looked into it all empirically, whether the like variance of those shocks at an individual level has changed over your time sample. I mean, you've looked a lot at the trends, perhaps, in what proportion of people of different ages are in these different health categories, and certainly how what their mortality risk is. But if we're thinking about this from a kind of insurance perspective, you're insuring yourself against these two different types of shocks. Have those shocks gotten harder to predict over time, or is that fairly constant?
Yeah, that's a great question. And it's a really good point because, and I've also like many times in this project doubled back to, wait, why are we just looking at means? The value of insurance comes from the variance. And so, and that's why we did a little bit by showing you that even conditional on, a bunch of those health measures, there's still variance in spending. Um, and has that changed over time is something we should look into, given that what we're finding is very little change in health spending over time. We haven't looked into that as much, but we definitely should, and we definitely can with our machinery. And, we have a bottom line result, but as I said, we're still trying to unpack it. And part of unpacking it is not just making sure we understand what's driving it, but saying in a counterfactual world in which we held the mean constant but increased the variance, how would that change things? What happens in these models, though, is a lot of it is driven by this consumption floor, which you kind of have to have, both in a realism sense, because people don't go to zero consumption, and in a modeling sense, because if you have any risk of going to zero consumption, which would be, infinite marginal utility of consumption, you would make sure you never ended up there, which is almost impossible to do because medical expenditure risks are not proportional to wealth or income. You can be,
Hmm.
I mean, health is one of the few risks, I think, compared to almost anything else, where the risk you're insuring doesn't scale with your income or wealth. So if you think about life insurance, which is not actually insuring that you live, but it's insuring, your earnings if you die, or unemployment insurance or disability insurance, those are all proportional to income. Even property casualty like auto and home insurance, it's not literally scaling with your earnings, but in practice, we know what Van Gogh curves are, and people who have higher earnings are buying, more expensive cars and more expensive houses. So there's a sense in which those are all risks that in principle in a well-functioning insurance market you can handle. And that's not true for health risk, because there is the possibility of getting a risk that you literally cannot afford, in the sense that it's bigger than your PDV wealth, even if credit markets were perfect. And so that consumption floor plays a big role, and I think ends up swamping changes in variance unless they're very, very big. Like the mean is going to be very important relative to that consumption floor, but we should of course look into it. Um, yeah.
Thanks very much. So, yeah, thinking about moving from distribution of outcomes to distribution across income, you've kind of touched on a little bit there. We've got a question here from Tiernan Evans asking, have you quantified the magnitude of the distributional impact of the suggested policy change, given the differences in healthy life expectancy, increases in health spending? Would these help the poorest the most compared to Social Security on the Medicare side? Or is it going to be benefiting the other end of the distribution more?
Yeah, so that's a great question. On our to-do list, once we understand better the basic model, is to do these calculations by gender and by income. I will say, having, touted the virtues of these data, I think where we start to hit their limitations are exactly on sort of the socioeconomic status dimension, both because we just have relatively small samples, and so then when you're cutting them, that's a problem. But more importantly, what you really would like to know is where in the income distribution they were at 66. And we are just able to say, where in the income distribution are you for other people of your age? And the reason that's problematic is that we know that mortality is much lower among higher income individuals. So someone who's closer to the bottom of the income distribution of 80-year-olds might have been quite high in their cohort's income distribution when they were all 66. And so I think to do that right, we would want to ideally bring in other data in which we could, say, even if you're 80 now, where in the income distribution were you at 66 because of this selective mortality issue, or at least try to gauge how big a problem that might be.
Thanks. Yeah, so sticking with questions more on the economics, and we've got a few more questions coming in more on the health side, but I'll try and stick with the more economic ones first of all. So we've got a question here from Carlo Ambrogio Favero, asking what the impact on the government deficit or implications for debt sustainability of these trends would be. So my understanding is you're holding the kind of the budget fixed, but in spite of these demographic trends, there are still going to be budget deficit implications of these policies, or not so much?
Yes, in the sense that you know, the demographic trends are pushing up spending both on Social Security by, I think it was about 14%, and on Medicare by about 9%. They're not as large as they would have been if we'd had the longevity improvements without the health improvements, but they're certainly, the direction is clear. So yes, and that's where I think all these questions that we've set aside on how should we handle this fiscal imbalance? Should we raise taxes? Should we cut benefits? Should we raise the retirement age, the benefit eligibility age? Those are the first order questions that many other people have been working on and talking about and thinking about.
Thanks. And so just another more economics focused question. We can't really have a discussion about these trends without talking about AI. So we have a question here from Alexander Iturralde, asking whether you think there is a relationship between AI adoption and demographic change here, particularly thinking about AI-driven shifts in labor demand, labor supply, moving retirement age decisions. So kind of linking back to our discussion earlier about should labor supply adjust, but as someone with expertise in this area and certainly aware of AI. Do you think there's going to be an effect there?
So I should say our data go through 2019. ChatGPT wasn't yet around. Almost surely will have effects on almost anything, how quantitatively large they tend to be. I haven't thought enough, and I should talk to some of my labor economist colleagues of how AI, if you think, say, that health is improving conditional on age and all else equal, that makes it the optimal age of retirement later,
Hmm.
right? How AI affects that, how it affects the sort of physicality of jobs, and how that varies by age is a very good question on which I don't have any immediate thoughts except to say it's a good question.
Thanks very much. So shifting more maybe to think about the health part of of the work you've talked about today. We've got a question here from William Parker asking if there's any important variation in the composition of morbidities or limitations over time, for example, between physical versus dementia, those sorts of things. I think that also links to, and again, to a broader question. You've got your 5 mortality groups and your prediction exercise where you go from all 31. But does it really matter in the data which of those 31 you have? Because those, if I understood correctly, those 5 mortality groups are just a sum across
Totally.
a number of those.
That is a terrific question. We can, in principle, answer that because we have all the predictors from,
Hmm.
the model. In particular, I think you can think of the activities of daily living and the functional measures and the physical health measures as all being physical health, and we then have some measures of cognition, um, like in the instrumental activities of daily living. And I think we can just look and do that, and we can and should. I have my rough sense is that cognition is going to primarily affect nursing home use and an independent or home health, independent living. But we could break out those trends when we say how have the at number of these limitations change over time. We could do the physical versus the non-physical. That's a great idea.
And do you have any sense of whether there has been a trend in just empirically over the sample period that you've looked at, that some of these ADLs or IADLs are becoming more of an issue than they were
I, I,
previously?
I just haven't looked, so I don't know. Someone may know because, as I said, other people have done this type of work. It's a great question.
So we've got a question from Eric French here, who's asking if you know how much of the cross-sectional variation in medical expending is explained by your health variables, and that's motivated, I think, by the fact that often medical spending is used as a proxy measure for health. And so I guess it speaks to which of those is a more appropriate measure to some extent. But do you have a sense for how much of that medical expenditure you can explain with the health measures that you have?
That is a very good question as well. I'm sure, I was saying I was pleased that conditional on all our health measures, age isn't really predicting medical spending. So that's not directly answering his question, except to say that, we seem to be capturing most of what age captures. There's a question of how much we are predicting. Again, I should look. I don't know. I guess the other thing that I don't fully know how to think about, but there's a whole industry of sort of risk scores, right? Of trying, for reimbursing insurers or, predicting people's medical spending. And my sense from that literature is that there's a sort of fundamental, like, unknown question, which is, you know, how much of medical spending is predictable, right? Like, is the right model that with all the data and a perfect, algorithm, you should be able to predict all of medical spending, or even, knowing, having someone's complete chart, medical charts, their family history, etc., is there some inherently stochastic? So we should know the answer to Eric's question, but even knowing it, I don't think the relative comparison is to one. People have come up with statements that say only 25% of medical spending is predictable. I'm not totally sure how they get that, but like that also seems relevant for thinking about. We should know the answer to his question, but then how to think about the results, I think, will also depend critically on how much you think is inherently predictable.
Thank you. That makes a lot of sense. So we've got a couple of, I think, related questions here, thinking about private health insurance in the context of your model. So Christina Barbosa asked quite simply, what the role of private health insurance is in your results, in your model. So maybe you could clarify that, and whether different assumptions about private health insurance would affect your results there.
Yeah.
And Martin Ellison is just in a related point, I think, here says that the US president is talking at the moment about putting money into people's pockets so they can buy their own healthcare. And from the outside, Martin is saying this seems to miss the whole insurance benefit. So with that in mind, where do you see US healthcare in the future? So both of those, I think, speaking to a kind of private versus public.
Yeah, so our model does not take into account private health insurance. It abstracts from a lot of things to just sort of begin to understand some of the key economic forces at play. I will say that between Medicare and Medicaid, which we're modeling through that C floor, I think you're getting, close to 85% of older ages medical spending. I think private health insurance, not counting private Medicare, which we are considering Medicare, so Medicare Advantage, other private health insurance is relatively small. There is some retiree health insurance and something called Medigap. We have not, relatively few people, but we haven't modeled it. I agree with the statement that giving people cash instead of health insurance undoes the whole insurance role of, or potential insurance role of health insurance. I will say that there has been for a long time in the United States, some push towards this in a particular context, which does make sense, which gets at a particularly idiosyncratic and odd feature of the US health insurance, which is the vast majority of health insurance in the United States is provided through an employer, and that anything that the employer pays for your premiums, they don't have to count in your taxes as taxable income. So there's a tax subsidy to the employer paying your compensation in the form of health insurance premiums rather than wages. If they give you $1 of health and pay $1 for your health insurance premiums, that's $1 to you. If they pay you $1 of wages, you only get, 1/1 minus tau of that as take-home pay. And there has been a view by many economists for a long time that, not only is that quite regressive because marginal tax rates are increasing with wealth and not with income, and not only is it potentially distortionary in terms of locking people into jobs and whatnot, but it also, encourages the sort of over provision of health insurance relative to wages because it's tax subsidized. And one of the proposals, I think that the best proposal to counteract that would be to eliminate that tax subsidy. But in the interim, there have been moves to have so-called health savings accounts within your employer in which you can put some of your earnings pre-tax into a health savings account, which you can use to then pay some of your medical spending out of pocket. So while the person who asked the question is 100% right that that undoes the insurance value, in this eighth best world we're in which there's this weird tax subsidy for employers to pay you in the form of health insurance, that might be a partial corrective of that. I'm not sure that that's what the current policy proposal is, but that is another factor that to take into account.
Okay, yeah, thanks very much. And then I think, well, getting quite specific on the US context there, but I think one thing that surprised me a little bit was your result that healthy life expectancy is kind of increased across your sample period in the US. Because other work I've seen and data I've looked at myself tell me that that maybe wasn't the case, particularly in the kind of 2010 to 2019, that kind of gap. This is like if you look at the global burden of disease data on healthy life expectancy for the US, there's a bit of a fall over that period in spite of life expectancy going up. So I was wondering if the fact that you find increases there, whereas other data sources, other people have found decreases, is that because of the sample period you're using, comparing to 93 being further back? Or is it just that the kind of health metric that you have is perhaps more holistic, is capturing more things that something like a years lived with disability metric misses? I don't know if you've got any.
Yeah, that's a really good question. We have started to, we started with these two, endpoints. We've started to do stuff in between. I believe what we are finding consistent with other work is that there's been a decline in the rate of improvement, but I don't think we've seen a deterioration. So I should actually look at the World Health Organization report you're mentioning, and I may email you if I can't find it. But without looking at it, it's hard to say what's going on. Um, but yeah, it's a really good question. And the most easy answer is, the change from 93 to 2019 doesn't have to be the change as 2010 to
Of course.
2019, but I'm not sure if that is the answer.
Sure. And then, so I'll hand back over to Andrew in a second to wrap us up. But I think one very broad general question, we've got a very international audience here. We've had a very US focused discussion towards the end here. So I don't know if you're comfortable speculating how much of what you've been talking about, the lessons that you can learn from your work are US specific here, or are there lessons for the broad trade-off between Social Security type programs and Medicare type programs that might be internationally applicable?
So usually I like to say, no, 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 don't generalize at all. But in this case, I have to say, all of the international work on the mortality and morbidity trends I have seen suggests that things are very similar, that other countries have also experienced these big improvements in life expectancy for the 66 plus and improvements in health conditional on age. So, to first order, you would think that that would translate into similar, changes in healthcare spending, although that would be very interesting for someone to do and see. And I think if assuming that's true, that the model we wrote down, I mean, yes, I called it Social Security and Medicare and Medicaid as the consumption floor, but especially for 66 plus, where we in the United States do have, universal coverage, unlike for people under 65, I think the basic, trade-off of a public pension paid as an annuity and a public health insurance program, I think applies. And so I would think that similar demographic trends would give you similar implications. That doesn't mean it's not worth doing, but I would actually think it actually does. The model, for all the limitations of, well, we didn't account for private health insurance in the United States, I guess the silver lining is it's a fairly general model. Yeah.
Yeah, for sure. Well, thank you very much, Amy. It's been great to talk, and thank you for everyone for putting their questions in. I'll hand over to Andrew now to wrap up.
Thank you, Julian. And first of all, thank you to Amy. I knew you'd be a great person to launch this webinar, and you certainly were. Both the manner of delivery and the content was spot on. The RPN focuses upon aging and longevity. It tries to look at the problems and the opportunities, and I thought that you did that. The positive side of most of the life expectancy gains are healthy is, of course, fantastic. Then it's, well, how do we change our institutions in order to support that? So thank you for the data, the theory, and the policy. Thank you, everyone, for joining us to listen. Make sure you are signed up for the newsletter so you know more about the future events. Spread the word so even more people can benefit from seminars like Amy's. Thank you, Julian, for expertly dealing with the Q&A, and to Megan for expertly dealing with the event and making sure everything went off without a hitch. And then just one final thing. This is a quarterly webinar. The next one will be on the 19th of February, 4 p.m. London time. We're delighted to have Dora Costa from UCLA joining us, and she'll be talking about the economy, the ghost in your genes, and the escape from premature mortality. So look forward to seeing you all again then. And thank you. And wherever you are, I wish you a very good rest of the day. Thank you, Amy. Thank you, everyone.